Right. So more cranials. We're getting into the more, I guess you'd say, the more complicated cranials this session. Um, so just a quick little review. Oh, my clicker's not working here. There we go. Just a quick overview. Cranial faults. Early on, when we first introduced cranial faults, I said there's basically three categories of cranial faults, and the flexion extension, which really has to do with the sphenoid in the basilar portion of the occiput. And then also looking at kind of the relationship between the sphenoid, since it is the center of the skull. It's like the keystone of the skull. Rotational cranial fixations, temporal bulge, parietal descent, and then we're going to be introducing internal, external, frontal, and then universal, and nasosphenoidal, which I didn't list in here. And the third category would be sutural faults, which can be anywhere there's a suture, really. And typically they are jammed. Often they're jammed. Sometimes they're separated depending on the suture. But we're going to be focusing next on some rotational faults, primarily the internal frontal and the external frontal. Hopefully this is a above-down view of the sphenoid, which is in greenish blue there, and the occiput, which is bone-colored. And I tried to put those arrows so you can see how if the sphenoid rotates around the junction of with the basilar portion of the occiput, and that would be indicated on the right. That would be an internal frontal fixation. And if it rotates the other direction, which is indicated on the left, that would be an external frontal. And we're going to go over the internal frontal first. So what would lead you to think you've got an internal frontal fault? Well, one of the signature findings with this one is anterior neck flexor weakness. Now, that can be caused by a whole bevy of things, but if you find weak anterior neck flexor weakness, especially on one side, if you have headaches characterized as like, ocular or pain behind the eye type headaches, and then, of course, looking at the patient, and with an internal frontal, the signature signs would be on the side of internal rotation will be larger nostril, nares, large nares, and then a smaller socket on that side. And on the other side, often you'll see a smaller nares and a larger orbit. So you're looking for, and it's rare that anyone's perfectly symmetrical, as far as the size of their orbits and their nostrils, but this is one of the things you can look at. Now, there'll be palpable tenderness over the supraorbital notch, and also, and I never use this one because I don't like pushing on people's eyes, but with the eyelid closed, there'll be tenderness if you gently press over their eye, but I'd rather use the notch and the TL and the challenge, but those are all signs that go along with this internal frontal. Therapy localization, they will therapy localize at the suprasternal notch. They will also therapy localize at the maxilla, kind of where the maxilla joins the zygoma. And of course, this picture is indicating that they're therapy localizing on the left eye. which would indicate you've got the internal frontal on that side. The challenge is going to be different. I read a couple different accounts just in reviewing this, and typically I push on the zygoma, and right near where the zygoma articulates with the maxilla. This picture, really, the arrow is pointing right at the maxilla. Try both, but you press straight lateral on the side that has the super orbital notch tenderness. Excuse me. And that will be often on the side with larger nares. Now, how do we correct it? So we've verified it by, say, we've got neck flexors, we've got a positive TL, suprasternal notch, and maybe also at the maxilla-zygoma junction. We've got positive challenge, left to right. How do we correct it? Well, the correction is 3 steps. Step 1 is on the side of internal rotation. We're going to press on the hard palate right near the junction of the last premolar and the first molar on the side of internal rotation. Now you can use eye pain or suprasternal notch, or if there's tenderness at the zygoma, to monitor your pressure, and you'll change the vector. You can change the vector a little bit and look for that optimal pain relief effect. Now, the vector, as you're pressing on this hard palate, and your patient, you can do this seated. I've done them seated, and I've done them supine. The vector is lateral and superior, as if you were going to roll that that hard palate. You kind of roll it around the sagittal. So you're up and out, like you're going to roll it around the sagittal axis. The next step, on the high sphenoid side, and this is where you're going to have the larger eye. This is the opposite side of the internal side. You're going to go to the pterygoid process, and you're going to gently, gently fish your gloved finger back till you find that. You're going to be lateral the pterygoid process off of the sphenoid, and you're going to bring your finger up kind of behind and on the side of it, and you're going to pull inferior. You're going to be as if you could pull. Now, there's not much to grab there, so you have to be very, very gentle. So you're going to gently pull down on that for about 10 to 20 seconds. Make sure the patient is breathing. Use the same approach you would with any other cranial. Gentle, feel more than you think, or at least as much as you think. Feel your way through cranials. And with any of these structures, less is more. Third step, you're going to go back to the internal side, which in these series of slides would be indicated by the left side, and you're going to press up on that pterygoid process for 10 to 20 seconds. So it's a 3-stage correction, and I'll video the demo of it. Now, I put in bold down here, please be very gentle with these pterygoid processes. They're easy to break. I've made some sore. I'm not sure I've ever broken one, but I've given people quite a sore throat from just a little too much pressure, especially when I was first learning how to do these. And you'll get a lot of the correction will happen with the pressure over the hard palate. Now, next, we are going to talk about the external frontal, which is basically, you'd think it'd just be the opposite, but it's still its own cranial fault. Just the opposite, you're going to have, you may or may not have scalene weakness. There's going to be nares imbalance. There's going to be smaller nares on the side of external frontal. The orbit's going to be a little bigger on the side of external frontal, and the eye may protrude on the side of external frontal. Palpable tenderness, the supraciliary notch will be tender on the side of external rotation, and the contralateral zygomatic malar arch will also be tender. TL is at the pterygoid process, so you have the patient reach clear up into their throat, which is kind of challenging. If you don't find it, if it's not like real clear, then you can rely on challenge. Now, challenge is interesting because the challenge is to pull the central incisors anterior inferior, kind of pull them down and now. Dr. Francis, I remember he said, make sure they don't have false teeth or partial. Now, if you do this challenge and you get a weak indicator muscle, you want to rule out neurologic tooth as well. You could have both, but neurologic tooth, then you'd want to challenge the tooth itself, A to P, P to A, buccally, lingually, like we talked about, breath in, breath out. Honestly, I don't find neurologic teeth in the front too much. I have, but it's pretty rare. I find them in the molars all the time, in the premolars. So that's the challenge. Now, how do we correct it? It's a 2-step process, not a 3. Now, you're going to be on the side opposite the external rotation, so you're at the spot. If you were correcting, say, the internal rotation from just a little while ago, you're going to go back to that same side, but now you're going to be pressing right near the last molars, about where the hard palate ends. You're going to press cephalad and slightly back, and you can once again use the tenderness. You can use muscle testing, but you can use the tenderness to monitor your vector and your effectiveness. That's step 1. Step 2 correction, you go to the pterygoid process on the side of external rotation, and pressure is applied cephalad and medial for 20 seconds. Once again, be very, very careful with pressing the pterygoid process. If you feel like you're pressing too hard, press less hard. If the patient feels like you're pressing too hard, then back off. So that is the internal and external frontal faults. Next, the nasosphenoidal fault / pituitary drive. So this fault has been associated with chronic visceral issues, endocrine issues, typically hypoendocrine. Basically, things are just really sluggish. Patients are always wanting to, get more energy, which goes along with most of the conditions that we treat. So the nasosphenoidal fault / pituitary drive, what led you to the process would be possibly if you're treating someone, you're finding that someone, either by lab or by AK or some other methods, you've determined that maybe they're hypothyroid, or maybe their problem is their pituitary. Very often the HP axis in general is off, and this is nothing new, I know, to talk about, but we find often the body expresses problems with adrenal function or thyroid function, and there actually is hypoadrenia or hypothyroid going on, but often the pituitary is not, optimally managing their part of the HP axis. So this is a simple procedure. It's easy to do. People tend to get really nice, get a really nice lift, kind of a rejuvenation from this. So the challenge is you press at the nasosphenoidal area toward the opposite temporosphenoidal line, which is indicated on the slide by you got the blue vector there against the green spot, which is the nasosphenoidal junction. And then you're monitoring over on the opposite side along the anterior part of the TS line. That is how we challenge it. We challenge, strong indicator muscle weakens, and then there's a phase of respiration. Usually it's inspiration will negate the challenge. Palpable tenderness often found along the TS line area opposite to the challenge. And of course, this is also the outline of the temporal fossa, which there could be issues with the TMJ. Of course, there often is issues with the TMJ when there's anything going on with the sphenoid or any of the other cranials. So this is a signature finding. Now, how do we correct it? I have tried doing these seated. Forget it. It's easier to have the patient very relaxed, supine, so you can really get one hand behind on the mastoids, and the other hand is going to be on the nasosphenoidal area. So you push the nasosphenoid area in the direction that challenged while you're doing a bilateral mastoid lift. Now, my hands aren't super big, and sometimes I get someone with a head. I can't quite reach there, and it's a real challenge. But most of the time, most of us can, with most skulls, we can get a span there and get like a index or like a middle finger and a thumb on the both mastoids. You're going to do 3 sets of 20. You're going to be pumping the mastoids while you're gently challenging that nasosphenoidal area. Now, there's a note here, hyperpituitary is when you find that they, and I actually have never looked for one, I've never found one of those. So there's also an associated sacrococcygeal respiratory fault that will accompany these. So you can check for that, and that's we can talk about that in the workshop. So that's the nasosphenoidal fault / pituitary drive. Now, when you find this, and you find it in conjunction with TMJ, there's other history findings. There's fatigue. There's all the indications that this patient is struggling with endocrine issues. You want to test. You want to go to the Chapman reflexes for adrenals, for thyroid. The pituitary Chapman is the glabella. I mean the right at the So you want to test for nutrition before you before you make this correction, because it's very good. You have some very good indicators. Anyway, so universal fault is our next one. Now, universal fault is also called an interosseous fault. A little while ago, we talked about the intraosseous subluxation. Intra meaning within the bone, and this is interosseous, so it's between two bones. This is another rotational fault between the occiput and the sphenoid. Only this time it's rotating around the sagittal axis, so an axis that would go from, say, through the skull, from the back of the head through the nasosphenoidal area. So there's this rotation around that axis. This could be found with long-standing gait problems. It can be found with a history of trauma, especially whiplash or any kind of head trauma. Posture, a lot of postural strain, people who are kyphotic, the occipit's always jamming, hypertonic upper traps, these kind of things, SCM imbalance. So you want to really watch for these. Indications, a strong muscle is made weak by breathing in through one nostril. Now remember, the glabellar fault is we breathe in through the nostrils and then we breathe in through the mouth. And a strong indicator muscle will weaken with nostril breathing or oral breathing, but not both. With this fault, we breathe in through one nostril, and a weak muscle or a strong muscle weakens. It is a rotational fault. It's a counter rotation of the sphenoid and the occipital bone around the sagittal axis, and this will cause a disrelationship with the temporal bones. So the mastoids we're going to be getting a hold of the occiput and the mastoids to make this correction. The tenderness found will be often over the occiput. The TL is going to be a two-handed TL over the occiput. However, that could also indicate what you are all thinking, I'm sure, a bilaterally inferior occiput, or it could indicate an occipital fixation causing a bilaterally weak psoas, if you remember back to our fixation patterns. So don't go solely on this, thinking you've got a universal. Also, Dr. Walter mentions that at one point the TL for this fixation would be a two-handed TL over one side of the occiput, kind of like what we do to differentiate the involved side on category 1. But suffice it to say, just have them TL the occiput in general. If that's positive and then you've got the other signs, go for it. The challenge is going to be on the mastoids. You challenge one mastoid up and the other mastoid down as you, at the same time. Now, you go one direction, then go the other direction. A strong indicator muscle will weaken if you have this fault. So essentially what you're doing is, if you can think of it as rotating, you're pressing a mastoid down and a mastoid up, and essentially trying to create a rotation around the sagittal axis involving the occiput. Now, if you find this and weakness occurs, you're going to go opposite. This correction is not a rebound correction. It is a direct correction. It's a direct challenge and a direct correction. So if you challenge it, say the way the arrows are in this slide, the right mastoid being pressed up, the left mastoid being pressed down, and you get a strong indicator muscle weakening, you're going to correct the opposite way. You're going to assume that what you're doing is pushing it further in a lesion, and you're going to push it back out of lesion. And the correction is done in the opposite, there we go, this on the slide, opposite direction that made the muscle weak. You make the contact on them. Once again, you need a nice wide grab here. The mastoids bilaterally and to both sides of the occiput. So one hand's on the occiput, as if you're going to turn it like a dial. The other hand is underneath, and the thumb and middle finger are contacting the mastoids. You're going to be pushing one mastoid and rotating the occiput the same direction as if you're working with a gear train. So if you challenged in this way, like right mastoid up, left mastoid down, your correction is going to be pushing the left mastoid up and the right mastoid down while you rotate the occiput clockwise, looking at the back of the patient. That would be your correction. 4 to 5 respirations. Now, there's a sacral fault, a couple of sacral faults that may be associated with this. One is sacral wobble. You remember from, I don't know how many sessions ago that was, but the TL for sacral wobble is the hands in a prayer position, lying right over your sacrum. And of course, atlanto-occipital countertorque, which is very similar. You've got a disrelationship between the mastoids and the atlas. Or you got a disrelation between the atlas and the occiput, but you end up contacting the area where the occiput articulates with the mastoid. So you want to check those faults when you find a universal fault. Now, the next section we're going to go into diaphragm, which is going to lead us into looking at the esophageal hiatus and evaluating for hiatal hernias or pseudohiatal hernias. So anyway, that's all for this clip right now. Stay tuned for the diaphragm.